Welcome to Senadhipan Education Foundation again. The greatest enemy of knowledge is not ignorance, it is the illusion of knowledge. Actually, we started this knowledge exchange platform way back in 2012 by releasing a set of educational DVDs by Professor Seon Han Kim, a colorectal surgeon from Korea. And then he visited our place. And then onwards, we are having contact classes in training and training programs in minimal access surgery. And we do hands-on training both in dry lab and in actual scenario also. We have 6 months and 1 year fellowship programs which are hands-on in basic and advanced laparoscopic surgeries, and we don't collect any fee. From July 2020 onwards, we made it into online platform because of the COVID. And actually the logo was released by none other than Dr. C. Palanivelu. And then onwards, we are having live surgeries in the online platform. We did the first live surgery in Facebook Live in April. That was a low anterior recession laparoscopically. Later in August, we did a lab people in YouTube Live. And the link was shared to the members of Senadhipan Education Foundation. We are having live lectures with the world leaders like Dr. V K Kapoor and Sadiq Sikora. We started distributing e-certificates for the participants when their screen time is more than 80% of the total webinar time. Actually, we have social media platforms. We have a Facebook group, Senadhipan Education Foundation Facebook group, more than 800 members, and we have almost 4 WhatsApp groups of 256 members each. And we finished our 25th webinar 3 weeks back, and this is 28th webinar of Senadhipan Education Foundation. We have got a global acceptance. More than 60 countries are logging in at a time. This is one of the largest virtual platforms in the world. You can see the number of countries which is logging in and the total number of participants. All the webinar videos are available for free view in the Senadhipan Education Foundation YouTube channel. You can subscribe it and see it when you have leisure time. Today we have 2 eminent people to describe or to give a lecture on benign biliary stricture. Actually, in the last meeting, I introduced Professor V K Kapoor sir. He was instrumental in starting the gastrosurgery department along with Dr. Rajan Saxena. I think it was in 1989. And he is now the professor of surgical gastroenterology, SGPJ. He is a good academician, clinician, teacher par excellence. I'm not introducing because Dr. Arun Kumar ML is there to introduce him and the moderator. Dr. Sadiq Sikora is the moderator who was also in SGPG and now moved to Sakra Hospital. So Dr. Arun Kumar is a surgical gastroenterologist who is HOD and associate professor of GI surgery, and he is a liver transplant surgeon working in GG Hospital and Gokulam Medical College, Trivandrum. He will be introducing the speaker and the moderator. Before that, let me tell the participants that you are requested to mute your mic. If possible, kindly acknowledge by renaming your device. Participants logging from outside India are requested to reveal their identity in the chat box so that the host can acknowledge you. Raise your hand if you want to intervene between the talk or session. Everybody will be given permission to unmute their mic if they want to speak something after the session. And if you are on a portable device, please mute your audio and hide your video. And while SAR is presenting, please hide yourself. I hide your video so that the clarity presentation will be more. Actually, we are temporarily stopping the programs because I like to take a break. After that, we will be coming out with another series of webinars. For temporarily, we are stopping today. For any queries, you can write to senadhipan@gmail.com. And I'm handing over the mic to Dr. Arun Kumar Ammal for introducing his speaker and the moderator. Thank you. Dr. Arun Kumar, you are on.
Sir, am I audible and my screen is there?
Yeah.
Respected teachers, my dear friends, special thanks to Dr. Baiju Senadhipan for two reasons: for inviting me to introduce the speaker as well as the moderator today. And more importantly, he has shown us how in difficult times a surgical teaching can be taken to a different level. It's the pandemic situation actually it was slightly fruitful to younger surgeons because they could listen to almost all the world leaders, most of the world leaders in surgical gastroenterology through online platform, that is through Senadhipan Education Foundation. And it's doing a very, very fantastic job. Thank you, sir. Thank you so much. It's a very special day for all of us who got some experience, at least from Department of Surgical Gastroenterology, from the prestigious institution, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, commonly known as SGPGI. Two eminent teachers is there with us today to discuss the one of the most important topics for any surgeon, any GI surgeon, that is benign biliary stricture. And thanks to our alma mater, SGPGI, for producing a good number of surgeons, GI surgeons, dedicated with passionate and about gastroenterology surgery across the length and breadth of subcontinent as well as across the globe. And me being one of the alumni, very, very proud to have taking part in this today's program. About the moderator for today, Dr. Sadiq Saleem Sikora. He's an alumni of Sanjay Gandhi Postgraduate Institute of Lucknow, a vibrant teacher, right now working as director, gastrointestinal surgery, Institute of Digestive and Hepatobiliary Sciences, Sakra World Hospital, Hubli, Bangalore. And if we start describing him, it will, another webinar is required to describe about him. But every student of him will admire that for any simple case or a complicated issue, he will have a very insightful learning. His logical way of thinking and sorting out complex issues are well known for all the teachers. He goes into minute details, even if it is a very simple laparoscopic cholecystectomy. What are the preoperative factors? What are the intraoperative findings? And how did the patient fare in the postoperative period? A very constant vigilance throughout the entire surgical process definitely belongs to him. Even in the desperate situations, this attitude that is never give up, that really hallmarks Dr. Sadiq Sikora, our teacher. About the speaker for today, Professor V K Kapoor. He is the professor of Department of Surgical Gastroenterology, SGPGI, Lucknow. It's very difficult to again describe him in one or two slides. Bouquet of international honors, huge bunches of national honors. He's a visiting faculty to all the continents and more than 7 countries. Extremely rich clinical and operative experience. He's a very favorite examiner, both for the examiner group as well as the students for various programs in MCH and DNB in surgical gastro as well as hepatobiliary courses. He's an invited speaker for a multitude of international and national conferences. And publications, there's a dearth of, there's plenty of it, more than 150 articles, and so many books on his name and chapters of many other books. But we know as his students, he's very passionate in gallbladder cancer, bile duct injury, biliary stricture, as well as pancreaticoduodectomy. In any GI surgery practice, it's very important to ensure patient and family safety, the entire team safety, as well as the institution safety. So this is a blend for him, and it's a research as from his initial postgraduate days till now. He's having a very good passionate dedication to research in surgical gastroenterology. The word doctor is originated from the word which means to teach. So he's actually a teacher as well as a doctor surgeon. So he's received, there is no surprise that he received the biggest medical teacher award in the country, that is Dr. B.C. Roy Award. In short, he's a diamond. Definitely, he has come through all the tough training and research and teaching. So that is why he is with us today. He is one of the greatest authorities, along with the entire fraternity of SGPGI Lucknow, to speak on bile duct injury, and mainly today's topic is benign biliary stricture. Thank you so much, Baiju sir. Over to you.
Thank you, Dr. Arun Kumar ML, for giving a wonderful discussion about the speaker and moderator. And I welcome both the moderator and the speaker to this platform. Actually, we are really honored to have the great teachers in our platform. I hand over the mic to Dr. Sadiq Sikora to conduct the proceedings.
Thank you, Dr. Baiju. First of all, congratulations to you for this tremendous service through your foundation, which you're doing, and we are bringing us all together to discuss these issues. So congratulations to you. Thank you, Arun, for the introduction. Let's get to the topic now. So this topic is about benign biliary stricture, and I suspect that it is primarily going to be addressed in context of post-cholecystectomy, bile duct injury, and bile duct stricture, is my presumption in that. The simple reason is cholecystectomy is the commonest procedure performed across the world. It is supposed to be a quick in and out, often a daycare procedure, but the consequences of that are long-lasting, challenging to manage, and have an impact both on the surgeon and on the patient equally. And therefore, it is a very, very important topic. And no better to talk about that than Dr. V K Kapoor, because SGPGI has been at the forefront of management, inputs, insights into how to take care of patients with benign biliary stricture, especially the post-cholecystectomy ones. And Arun has introduced Dr. Kapoor, who I think is a teacher par excellence, an excellent communicator, and a speaker who would be able to sort of grip the audience and communicate important features about this problem and how to manage that. So I'll hand over the stage to Dr. V K Kapoor to talk about benign biliary stricture. And then I expect a very vibrant discussion, considering we have Dr. Kaushik, Dr. Rajan Saxena, and a host of other luminaries also attending this meeting. So I expect to see a very, very vibrant discussion at the end of this. So Dr. Kapoor, may I invite you?
Okay, Dr. Baiju, you can see the...
Yeah, we can see, sir.
And I'm audible well?
Yeah, can you make it a full screen?
It is
full screen.
It's showing as a full screen?
Yeah.
I think it is, yeah. Good evening, everyone. Thank you, Dr. Baiju, for giving me this opportunity. And I thought that it was only the cake, but when you informed me that Dr. Sikora is going to moderate, that became the icing. But now I realize that there are multiple layers of icing. Arun is there. It's an honor for me, as well as I'm sure for Dr. Sadiq and Arun, that Dr. Kaushik, who was the founding professor and head of the Department of Surgical Gastroenterology at SGPGI, in spite of not having keeping well in the last few days, is there to attend. Thank you very much, sir, for your presence. I am also honored that Dr. Rajan Saxena, who is currently the head of the Department of Surgical Gastroenterology, is also there. And what I'm going to talk about is actually, as Dr. Sadiq said, the work and the philosophy of the department at SGPGI. I discussed this with Dr. Baiju and checked that since a large number of people in the audience would be general laparoscopic minimal invasive surgeons who would be doing cholecystectomy more frequently than repairing a biliary stricture, I thought it would be prudent to cover the topic of bile duct injury, also the acute bile duct injury, which then eventually leads on to a post-cholecystectomy benign biliary stricture. And I'll spend some time on dealing with benign biliary stricture also. So the students in the audience, that's my email address, vkkapoor.india@gmail.com. If you need any more information or literature on bile duct injury, please make a note. You can always email me and I can send you more reading material on bile duct injury. So why is it important? As Dr. Sadiq said, that cholecystectomy is one of the common procedures that we all do. And in most of the cases, in almost all cases, things go on very well. Patient goes home the next day, but sometimes there is the problem. And this problem can then become a very big issue. The most unfortunate event would be if there is bile leak, bile peritonitis, which causes multiple system organ failure and the patient dies. And it happens. Or it could be a major biliovascular injury. And there are now reports of cases requiring an urgent liver transplant for a major biliovascular injury following just cholecystectomy. Or it could form a biliary stricture, which then requires a repair in the form of hepaticojejunostomy, which is not an easy operation. And sometimes, if there is an associated vascular injury, it may require a liver resection. This repair can fail in about 10, maybe 15% of cases in the long term, leading on to cholangitis, secondary biliary cirrhosis, again, either causing death or needing transplant. And even if the procedure is successful, it requires long-term and preferably lifelong follow-up. Now, since we've been repairing biliary strictures for last 30 years at SGPGI, we are seeing patients coming back after 5, 10, even more than 10 years with a recurrent stricture requiring reintervention. And I would suggest or request all of you to read the story written by this girl who now is a radiologist, a consultant, who underwent a cholecystectomy, had a bile duct injury, required a repair and required a re-repair, and then a resection, a liver resection, which tells you the non-medical, the social, the economic, the financial, and the psychological aspects of a bile duct injury. This was published in National Medical Journal of India. So those of you who want to read this story, please email me. Don't look at the figures. They are just there to highlight the bottom line, which is that it is well accepted now that the incidence of bile duct injury during laparoscopic cholecystectomy is around 0.5%. That means 1 in 200 lap choles will have a bile duct injury, irrespective of where the cholecystectomy is done or who is doing it. And this number or this incidence is actually higher if you look at data from countries like Sweden, or Finland, where there is a national registry of operations and complications, where every operation, every complication is recorded, as opposed to retrospective chart review reporting of bile duct injury. So there is no doubt that the risk of bile duct injury during laparoscopic cholecystectomy is definitely more than what it used to be during the open cholecystectomy era, about 2 to 3 times. So 1 in 200 is the accepted incidence or risk of bile duct injury during laparoscopic cholecystectomy. One may think that injury occurs in others' hands. It will not occur in my hand, but that also is not true. And there are surveys done in countries like US and Canada where there are good training programs, strict monitoring, that 1/3 to half of surgeons who were interviewed said that they have had at least one bile duct injury during their career so far. And many of these injuries occurred after the surgeon had done almost 200 laparoscopic cholecystectomies. And I'm sure we all know surgeons who have done in our country thousands of lap choles, and still they have had a bile duct injury. This multinational survey done in Japan, Korea, Taiwan, and some surgeons in US reported that as many as 3 out of 4 surgeons reported either a bile duct injury or a near miss. Near miss means that a bile duct was about to be injured when the surgeon realized that there is something wrong. Similarly, 50% of members of SAGES had had a bile duct injury. And very recently, during the COVID lockdown, since we had little time and on our hand, my colleague Dr. Supriya and us, we did a survey of the Indian surgeons, and out of 278 surgeons who responded, as many as 86% had had a bile duct injury, and many of them had had more than one. When lap chole was introduced, it was thought that bile duct injury is a part of learning curve, and once it becomes a accepted procedure, once it becomes a part of the residency training program, this incidence will come down. But again, data from Sweden, and as I showed earlier, data from all over the world has shown that this has not happened, and everybody agrees that bile duct injury is an inherent problem, or we might say complication, of lap chole per se, as opposed to the open operation. While I'm talking, keep looking at this picture. Don't read what is written on the slide. Just keep looking at the picture. And this is what happens during laparoscopic cholecystectomy. What one thinks is a frog is actually the head of the horse. So the surgeon thinks that it is the cystic duct, but actually it is the bile duct. Because a normal size bile duct, which could be 3, 4, 5 millimeter, may look like a wide cystic duct. And I still remember distinctly, more than now 25 or even 30 years ago, the first CBD which we transacted in our department was something like this. The operating surgeon thought that it is a wide cystic duct, asked for large size clips, applied the clips and cut it. And then we realized that it is actually the common bile duct. And this is because of a visual perception error. Because once you start presuming that it is the cystic duct, you don't think that it could be common bile duct also. And then you mistake the right hepatic artery for the cystic artery. And that is why there is a combined biliovascular injury. So there are various ways that you can avoid it, prevent it, or reduce it, the risk, including intraop cholangiography, including intraop laparoscopic ultrasound, including now fluorescent cholangiography. But these things require equipment, they require expertise, they require logistics. So the easiest way is what I call an in-vicinity cholegography. In-vicinity cholegography means that when you are doing a lap chole, before you clip or divide any structure, ask any colleague of yours who is in another theater, maybe senior, maybe contemporary, may even be junior, but not involved in this case, to give an opinion as to what you are thinking about the anatomy is correct or not. Because that person comes with a fresh mind. He or she is not suffering from the visual perception error which you are or your team is suffering from. And to some extent, an injury, the classical laparoscopic bile duct injury, can be avoided. Unfortunately, bile duct injury is not a simple complication. It's not an easy complication. It's not a complication which can be brushed aside, because the mortality associated with a bile duct injury and the consequent bile leak and peritoneal sepsis is significantly high. There are reports, and even in the survey that we did recently, 37 out of 728 injuries which were reported by these 278 surgeons ended up in a mortality. So 5% mortality of acute bile duct injury in our survey. And there are other reports which report 2, 3, 4% mortality. So the mortality of acute bile duct injury and consequent bile leak can be as high as the mortality of any surgical procedure that we do, whether it be total gastrectomy, esophagectomy, pancreatic duodenectomy, or even liver resection. Now, intraoperatively, if you see bile at any stage of dissection, it is, as I am fond of saying, like the yellow signal on the traffic. What does yellow signal mean? Yellow signal means that you stop, you look here, you look there, and if things are clear, then only you move. And that is what should be done if you see bile during cholecystectomy. So there are two situations. One is that you see bile when you are doing dissection in the Callot's triangle. And this is more problem or a bigger problem as compared to when you see bile when you are dissecting the gallbladder from its bed, because then you know that it is most probably from the gallbladder. Also notice that if you see this thin, watery, golden yellow bile which flows freely as compared to greenish, thick, viscid fluid which doesn't flow very freely, this probably is CBD bile and this is gallbladder bile. So if you see bile here, you must stop, you must evaluate, reevaluate the anatomy. You should not do any further dissection. You should definitely not clip or divide any structure, because yes, you have caused a bile duct injury, but at least you should not be complicating it further. The intraoperative management to a large extent depends on who are you. What do I mean by who are you? Whether you are a general laparoscopic or minimally invasive non-biliary surgeon, or whether you are a biliary surgeon. And according to me, the definition of a biliary surgeon is one who does a hepatico-jejunostomy as an elective procedure, as a routine, not once in a year, as a routine during either choledochal cyst excision, as a part of pancreatic duodenectomy, as a part of cholangiocarcinoma excision, or in the form of repair of a established benign biliary stricture. So if you do that as a routine, you are a biliary surgeon and you can tackle the bile duct injury according to the principles of management. But if you are a non-biliary surgeon, which is going to be the case in majority of the cases of acute bile duct injury, the easiest best and safest option is to drain. Don't do any further dissection. Leave two drains, suction drains through the ports of lap chole. Don't even convert. And what this will achieve is to convert the acute bile duct injury into a controlled external biliary fistula, which will not kill the patient, which will give you time to either arrange for management in your own hospital with the help of radiology and endoscopy, or refer the patient to a biliary center where these facilities are available. So no need to convert unless you are a biliary surgeon and you want to repair the injury. Some groups recommend clipping or ligating a divided duct so that there is no bile leak, but literature evidence doesn't support that, because even if you clip or ligate, that is going to give way in a large proportion of cases, and ultimately bile will leak. So even if you clip or ligate, which I don't recommend, you should leave a drain. Some groups recommend trying to pass a tube into the bile duct, either a completely divided or a hole, but that also I don't personally recommend, because trying to pass a tube laparoscopically into a hole or into the divided CBD is not an easy task. And while trying to do that, you can cause further damage. If you are a biliary surgeon, yes, you can try to repair the bile duct injury, which, depending on the type of injury, whether it is partial or complete, could be repair over a T-tube, an end-to-end repair, or a hepatico-jejunostomy, although the best option is to do a proper Roux-en-Y open. I personally suggest open hepatico-jejunostomy if you are a biliary surgeon and you have recognized the CBD transaction intraoperatively. this group from England has described what they call an outreach program. So if you're not a biliary surgeon, but there is a biliary surgeon available either in the same hospital or in the same city who can come to your theater during the operation and then help you to manage the bile duct injury, that is what should be tried to be done. But what about intraoperative repair? This survey from the French Surgical Association, where 640 bile duct injuries were repaired, immediate means intraoperative repair, was done in 194 cases. As is expected, most of these were suture repairs for a partial injury, and only 37 were biliary enteric anastomosis, but the failure rate was as high as 64%. Every 2 out of 3 immediate intraoperative repairs failed during the follow-up and required further intervention. The criticism of this experience was that since this was a survey of surgeons who had done the biliary injury and did the repair themselves, most of them were probably non-biliary surgeons, and that is why the failure rate was high. But we also, I think I'll come to that a little later. Now, unfortunately, during lap chole, in most of the cases, the bile duct injury is not recognized intraoperatively. The surgeon thinks everything is fine, but there is a bile duct injury. And most of these cases manifest in the early postoperative period. So how to suspect a bile duct injury? Following lap chole, the next morning, if the patient is not absolutely all right, like this young girl, this is on day 1, and she says, "Doctor, can I have a selfie with you?" So if the patient is not absolutely all right, that means she's not sitting up in the bed, she doesn't say hello, namaste, or good morning to you, she's not had a cup of tea, she has not been to the toilet, that means she's not well. And or if her vitals are not absolutely stable, which means she has some tachycardia or tachypnea or hypotension. And if the abdomen is not completely settled, which means that it is not soft, it is tender, it is slightly distended, and bowel sounds are not normal. So if any of these conditions is there, this patient is not to be discharged irrespective of what your units or departments or hospitals or insurance companies policy is. She must stay in the hospital, she must stay under your eyes, and she should be further investigated. Because if the patient is not well, if the vitals are not stable, if the abdomen is not settled after a lap chole, it is bile duct injury and bile leak unless proved otherwise. And unless proved otherwise can be only by observation and further investigation. So very high index of suspicion is very, very important to have early detection of a bile duct injury and its timely management. So please do not discharge a patient who doesn't fulfill all the 3 criteria: patient, vitals, and the abdomen. Now, if there is a suspicion based on these parameters, what to do? Obviously, you would do counts and liver function tests. You must do an ultrasound, but if the suspicion is high and ultrasound is normal, please proceed to cross-sectional imaging. Choice is yours. You want to do a CT, or since many of these patients are young women, I may prefer an MR imaging. Isotope scan is of use if the index of suspicion is low, because isotope scan is very good to rule out a bile duct injury. If you do an isotope hepatobiliary scintigraphy and you don't see any extravasation of isotope outside the biliary tree, it virtually rules out a bile duct injury. ERC is not indicated at this stage unless you suspect that the cause of bile leak is a CBD stone, because then endoscopic intervention will be therapeutic also. And the advantage of an MR imaging is that you can do a cholangiogram also, which gives you information about the biliary ductal continuity, which is a very important information to decide the further course of management, as we would see. The management of an acute bile duct injury and bile leak is, 1, to drain the bile. the first thing to be done is to let the bile out from the peritoneal cavity, because bile in the peritoneal cavity, even small amount, can cause sepsis, systemic sepsis, multiple organ dysfunction syndrome, and death. The first mortality that we had following lap chole and bile leak in the department was a patient like this, who had gone home on day 1, came back to the emergency after 2 days with some non-specific symptoms, which were ignored by the emergency medical officer by giving some symptomatic treatment. No further investigation, no even surgical consultation was done. Patient came back again, but by this time had gone into irreversible multiple organ dysfunction. When we re-explored, we found very small amount of bile in the subhepatic fossa, but he had entered into the vicious cycle of multiple organ dysfunction and finally died. So bile has to be drained from the peritoneal cavity. And if you have a good interventional radiology support, in most of the cases, this can be done percutaneously. Even multiple PCDs may be required. We have an excellent radiology support. So I don't think in the last 5 or 10 years, we would have explored surgically a patient to drain bile. Hardly ever. But if you don't have that support, yes, you can do surgical exploration, which in the early post-operative period, day 1 or day 2, could be a re-laparoscopy rather than a laparotomy. And if not, then a laparotomy. Second step, once you have drained the bile from the peritoneal cavity, preferably by percutaneous catheter drain placement, is to drain the bile duct to reduce or stop ongoing bile leak. And this is where information about ductal continuity is very important. Now that can be done either clinically. So if the patient says that she has passed colic stool, you know that most probably the ductal continuity is there. You could do an MR, you could do an isotope scintigraphy. And there are some people who say that no, we will see it at ERC only. We will directly go for ERC because at the same time, if the continuity is there, we could do a therapeutic intervention. So it depends on the philosophy of the unit or the hospital or the department. But you have to drain if the continuity is there, you place a stent or you can place an ENBD, endoscopic nasobiliary drain. The advantage of that is that you can do a repeat cholangiogram very easily and you can remove it without a repeat endoscopic intervention. So my philosophy is that if the ERCP reveals that it is a so-called minor leak, either from the cystic duct stump or a subsegmental duct, a minor lateral injury, which you know is going to stop in a few days' time, then you may place an ENBD because you know that after a few days the bile leak would stop and you can remove it. But in most cases, you will have to place a stent. PTBD would hardly be ever required if you have good endoscopic support. So drain bile from the peritoneal cavity and drain the bile duct to stop or reduce the ongoing bile leak. Now, this will convert the acute bile duct injury into what will be known as a controlled external biliary fistula. That means all bile is coming out through the drain. There is no bile in the peritoneal cavity and sepsis is controlled. So this patient can go home with a controlled external biliary fistula. What happens to the fistula? If it is a cystic duct leak, if it is a small lateral leak from the bile duct, a small hole, which means a partial or an incomplete injury, this bile leak will stop over a period of time. It may be 2 weeks, 4 weeks, 6 weeks, or a little longer than that. And not every patient will form a biliary stricture. So we have shown that if you have a partial or an incomplete injury, in more than 90% of cases, the bile leak would stop. And about half of these cases will form a stricture, which will then require an intervention. But if it is a complete transaction, still bile leak can stop in about 50 to 60% of cases. But in a good number of cases, the fistula will never stop. It will not show a trend towards stopping. And you will have to intervene. Obviously, all these patients will require a repair because there is a complete transaction. And you may have to intervene even with an ongoing external biliary fistula. The issues are when to do the repair, what repair to do, and who should repair. Now, early repair. This is the same study which I quoted earlier, where I talked about the immediate repair, but 200 patients underwent early repair within 6 weeks. And in this group, again, the failure rate was more than 40%. That means 1 out of 2 or 2 out of 5 repairs failed. As opposed to delayed repair, they call it late, but I think I can prefer to call it delayed repair. Late means that you are late, but delayed means that you have intentionally delayed it. The failure rate was only 7%, and most of these patients had undergone a biliary enteric anastomosis. Early repair, even when it is done by HPB surgeons. Now in Finland, it's a national policy that all bile duct injuries have to be referred to one of these 5 HPB centers. So when they looked at 140 repairs done at these 5 HPB centers, repair done within 5 days, which means an early repair, the mortality of repair was 4%, and the restricture rate was as high as 30%. That means 1 out of 3 repairs done within 5 days of an injury, even by hepatobiliary surgeons, all repairs done by hepatobiliary surgeons failed. Of course, many of them could be recovered or corrected by percutaneous intervention, but a significant number required re-HA, and the final success rate was 95%. This is a very recent systematic review and meta-analysis of early repair, which again shows that repairs which are done after 6 weeks, repairs which are done by hepatobiliary surgeons have low failure rates as opposed to early repairs which have a higher failure rate, and the need for revision surgery also is less. Who repairs is very, very important. In fact, I think more important than when you repair is who repairs. And again, this shows that the best results are obtained when a repair is done by a specialist surgeon and it is in the form of a Roux-en-Y hepaticojejunostomy by a hepatobiliary surgeon. Those are the cases which give the best results. And what is the procedure? Without going into the details, it is an anastomosis at the biliary ductal confluence. And that is why I prefer to call it a hylojejunostomy, because it has to be done in the hilum of the liver. Hepaticojejunostomy is what you do when you do a pancreaticoduodenectomy above the cystic duct level, when you do a choledochal cyst excision, a subhilar anastomosis. But this is an anastomosis at the hilum, which involves the horizontal extrahepatic part of the left hepatic duct and the right hepatic duct. Of course, if it is a bismuth type 4 stricture, even this is not possible. And then you have to do maybe 2 anastomoses, one to the left duct and one separate to the right duct. So it has to be to a proper Roux-en-Y limb, mucosa to mucosa, single layer, long-acting absorbable suture, preferably interrupted anastomosis at the hilum of the liver at the biliary ductal confluence. Before you do the repair, you have to do a proper workup of the patient, and the most important is the cholangiogram, because you need to know the biliary anatomy. You need to know what is the type of stricture. If it is a high stricture, whether the ducts are separated, is it only left-right separation? Is it anterior-posterior also on the right side, which are separated? And then the ancillary investigations, especially in late cases, an upper GI endoscopy and fibroscan to document whether there is cirrhosis and portal hypertension. Patients do require preparation like any other patient with jaundice. PTBD is rarely required unless the patient has uncontrolled cholangitis. Otherwise, unlike in liver resection or as some people do in PD, we don't do a biliary drainage irrespective of the level of bilirubin. So bilirubin level is not the indication, it is only cholangitis. PTBC, which is percutaneous transhepatic biliary catheterization, especially in a stricture like this, where you know that it will be very difficult to find these intrahepatic right anterior and posterior sectoral ducts. A day before surgery or on the morning of surgery, you ask your interventional radiology colleague to pass a catheter, a guide wire, right up to the hilum, right up to the tip, so that you can use it to identify the duct intraoperatively and to use it as a transhepatic stent across the anastomosis. And intraoperative ultrasound and intraoperative cholangiogram can also help to locate these ducts, and you need the help of your radiologist in the theater. So if you are dealing with a difficult stricture, make sure that you do all this preparation before you take the patient for surgery. I would not go into the details of technique of hepaticojejunostomy, although I have included a slide, but maybe I'll just briefly mention the points. A generous incision, a self-retaining retractor for the right costal margin, take the adhesions down very carefully, protecting the colon and duodenum, moving from right to left. So bring the hepatic flexure, transverse colon, and then duodenum down. Lower the hilar plate. Identify the extrahepatic part of the horizontal left hepatic duct. Look at the cholangiogram preoperatively, whether you are going to have a good anatomy where the duct is horizontal or an unfavorable anatomy where the left duct is vertical, so that you don't expect too much of extrahepatic duct. Make a good stoma as big as possible. So extend your incision into the left duct, across the confluence into the right duct. Make a good 45 to 60 centimeter rule loop. Place the drain before you do the anastomosis. We do that as a routine in any biliary or pancreatic reconstruction, because trying to position the drain after the anastomosis has been done puts some stress on the anastomosis. So place the drain and then do the anastomosis. These are some controversial aspects, whether those preoperatively placed catheters should be left proximal to the anastomosis to decompress the biliary tree, which is called proximal biliary drainage, or do you take them across the anastomotic to be used as an anastomotic stent, and whether you create an access loop. These are debates and controversies, which if anyone is interested, we can discuss during the discussion. Last point about bile duct injury is the medico-legal aspect. As Dr. Sikora also said, that it's a complication not only for the patient, but for the surgeon also. And the factors which cause a medico-legal case to be filed against the surgeon are delay in suspicion, delay in imaging and diagnosis, attempt to repair in the initial hospital, and obviously the death of the patient. If you have taken a proper informed consent, if you have done a good documentation of the operative findings and operative procedure, preferably a video recording, and in case a bile duct injury occurs, if you provide honest, truthful, complete information to the patient and relatives, and you manage the patient appropriately at your own hospital, if it is a biliary center, and if not, timely referral of the patient to a biliary center. These are the factors which will protect you even if a case is filed against you. So I would like to end up by saying that all bile duct injuries are iatrogenic. Traumatic bile duct injuries are case reports. Most bile duct injuries result in morbidity because of bile leak and peritoneal sepsis. Many of the bile duct injuries can be prevented by following the tenets of safe cholecystectomy. Some of the bile duct injuries can result in litigation, as was shown in our survey also. But all bile duct injuries should be managed preferably at a biliary center. Biliary center means a place where expertise, equipment, and facilities for interventional radiology and therapeutic endoscopy are available. The management of the bile duct injury depends on the time of detection, intra-op or post-op, type of injury, partial or complete, and very importantly, and in my opinion, most importantly, the expertise of the surgeon, whether you are a general or non-biliary or a biliary surgeon. The easiest, safest, and most effective option to save the life of the patient for a general surgeon who's not working in a biliary center is to drain as soon as you have a suspicion of a bile duct injury. Not convert, but just drain the abdomen and convert this into a controlled external biliary fistula. Early repair is not recommended, except in some situations, very few exceptions. The best management is to try to convert the injury into a fistula, which may then form a stricture in some cases, and then do a delayed repair in the form of a Roux-en-Y mucosa to mucosa hyalojejunostomy. So injury is a mishap, but to miss it is a mistake, and to mismanage it may be considered by the court of law or consumer forum as negligence. So thank you once again, Dr. Baiju, for asking me to talk about this topic, and inviting Dr. Sikora to moderate this. And thanks to all the audience for the attention. Both I and Dr. Sikora together will be happy to take questions and comments from the audience. Thank you very much.
Wonderful presentation, sir. Thank you for the presentation. And once again, we are really honored to have you in this platform. Today, you can see the participants, almost nearly 300 people are already in the platform. And I hand over the mic to Dr. Sadiq Sikora to moderate the session.
Thank you, Dr. Kapoor. As usual, you've made very specific and important points. We all realize that these are things which need to be paid attention to, and you've taken up the acute biliary injury and also the bile duct stricture. I already have a few questions here, and we'll just mold it into it, and then I will ask some of the other experts who are logged in, whom I know, to also comment. So first thing was about the acute biliary injury, and you mentioned at one point that ERC, some people may prefer to do an ERC. I think it's a very contentious issue about whether to do an ERC in a patient with acute biliary injury, and the timing, whether to do it straight away or after some. And one of the participants have also posed this question, that would you do an ERC or recommend doing an ERC straight or after a certain cholangiogram, and in this situation, MR cholangiogram.
Yeah.
So
there are two schools of thought. There are people who are aggressive. They say that since there is a bile leak, we would like to drain the bile duct and we would go for an endoscopic cholangiogram, which will also tell us whether biliary ductal continuity is there. And the other advantage, as I mentioned in passing, is that in case there is a small stone in the CBD, which is responsible for the cystic duct blowout, it can be tackled at the same time. On the other hand, there are surgeons like me and like us in SGPGI who are a bit conservative on asking for an endoscopic intervention in a bile duct injury. What we would do is that after draining the bile from the peritoneal cavity by percutaneous catheter drainage, we will see the course of the patient and the course of the bile leak. If the patient is stable, if the patient is not showing features of sepsis, and if the bile leak is not large and is not increasing, we will see its course over the next 2 or 3 days and then decide whether to go for an endoscopic intervention. Now, if cost and availability is not a constraint, ideally, theoretically speaking, yes, an MRCP before an endoscopic intervention is always good because it tells you what is happening and whether the ductal continuity is there. And in fact, some endoscopists also insist on having an MR cholangiogram before they go for an endoscopic intervention in an acute situation like this.
So I subscribe to the latter view also, that, I've seen significant complications related to indiscriminate use of ERC post-cholecystectomy bile leak without knowing what is the purpose of that. And as you realize that introducing infection and sepsis in a sterile biliary field may create more problems than otherwise one would like. Also, the fear about MR in acute phase, I think, is unfounded, and you can safely do an MR, although it takes a little longer, and in a very sick or unstable patient, it may not be a good test to do. But in general, if you want to do a MR, it can be performed, and you would have a roadmap which would help you, see whether endoscopic intervention is fruitful or not. I mean, if you have a transection and a loss of length of bile duct, then there is no point doing an endoscopic intervention.
Just one point. Before we go for an MR, we have to make sure that the biloma is drained, because otherwise the biloma in the subhepatic area will obscure the anatomy and will not give a good visualization.
So one question again is by Dr. Murlidhar, and he has suggested, he's posed this question, and we are talking about this acute biliary injury and external biliary fistula. Once you form, says how long to wait? That's the, always the question, that how long to wait before you repair a bile duct injury which has resulted in an external biliary fistula.
Yes. So that will depend on the type of injury, whether it is a partial, lateral, or incomplete injury versus a complete transaction of the common bile duct. As I mentioned earlier, if it is a partial, lateral, incomplete injury, and more so if we have been able to place an endoscopic stent, very high likelihood, more than 90-95%. In fact, Dr. Bismuth says that all of them will close if you wait for enough time. And the time limit for waiting, nobody knows, but most groups agree that you should not wait for more than 6 months, because then you run the risk of developing secondary biliary cirrhosis. So if it is a partial, lateral, incomplete injury, if the fistula output is gradually going down, I would wait. And in almost all these cases, the fistula will close before that period of 6 months, and then you will have some dilatation and you can do the repair. On the other hand, if it is a complete transaction and the fistula output is not showing a trend towards closure, I know that there is a very high chance that this fistula will not close even if I wait for 6 months. And therefore, if the fistula is not closing and the patient has recovered well from the first operation and from sepsis, you can do repair even with an ongoing fistula. Of course, the ducts will not be dilated, but at the same time, the fistulous tract will lead you to identify the duct. So there is no hard time frame, but definitely in no case I would or anybody would like to wait for more than 6 months.
So is it fair to say that roughly 6 to 8 weeks in a good anatomy fistula and a little longer in a bad anatomy, hilar with ductal separation? Would that be fair?
Yes, yes.
I remember listening to Dr. Blumgard, if you remember, at All India Institute, the 3 Bs had come, Bengmark, Bismuth, and Blumgard. And Professor Blumgard was very fond of saying that in external biliary fistula, I will wait till the patient is frustrated. I will wait till the surgeon is frustrated. And then I'll wait till both of them are frustrated with each other, and then would consider. So I think that was at that time, but I don't think that is what we need to, and it is okay, and it should be fine to repair bile duct injury with an external biliary fistula, given adequate time, controlled sepsis, and a good anatomy, or certainly having a good documentation of anatomy before we go in, especially in patients with external biliary fistula. There's also one more question which has come up by Dr. Taha Abdel Kader Ahmed. What is the best classification of bile duct injury?
I can't say best, but the most commonly and followed by almost all groups is the Strasberg's classification. It has its own limitations, which I have highlighted in one of my publications, and even in this book, I have addressed this. Recently, the European Association of Endoscopic Surgery came with a very extensive classification, which tried to include everything. But it's so complicated that I think even in a prospective study, people will find it difficult to apply. In my opinion, and that's what I have suggested also, there are 3 things which are important to classify a bile duct injury. One, the bile duct which is involved, whether it is a major duct or a so-called minor duct. Second is the circumference involved, whether it is a partial injury or a complete transaction. And sorry, B was for bile leak, whether there is bile leak or not, because suppose you have a clipped duct or a ligated duct, there is no bile leak, but there is a bile duct injury. And D is the duct, So you could have bile leak, but no bile duct injury, because some classifications do not include cystic duct blowout or cystic duct leak as a biliary injury. Obviously, it is not a biliary injury, but we must not forget that it is bile leak. And the immediate morbidity and mortality is not because of the injury, it is because of the leak. So even a cystic duct leak can kill the patient. And the report from Amsterdam has shown that even in the so-called minor injuries, the mortality was there. So it is bile leak, the circumference involved, and the duct involved. These are the three important factors. Of course, the most commonly used classification is the Strasberg's classification.
So vascular injury, because vascular injury is generally not addressed by any of these classifications except the one from Germany. One of this classification had addressed the vascular injury also. I think one of the most basic shortcomings of most classification is the absence of consideration for vascular injury. The one which has been, I think it's from Mannheim, the vascular injury classification which had been proposed, it becomes very complex and it's very difficult to address it and use it in clinical practice. Of course, it is a good thing for documenting all the extent of injury and the vascular injury. So I agree that most often all of us for acute injuries would use Strasberg classification, and then with a bile duct stricture, still Bismuth's classification remains the key classification. Yes.
Just to complete the story about vascular injury, in lap biliary injuries, vascular injury, if you look for it by doing an angiogram, CT or MR angiogram, the incidence is very, very high. And the implication of vascular injury is it doesn't, to a great extent, alter the management either of the acute injury or of the biliary stricture, except that if you believe in early repair, you should not be doing it if there is an associated vascular injury, number one. And number two, if it is a very high stricture, a bad type 3, when Dr. Sikora was with us, he had described that even bismuth type 3, they are all not same. There is a good bismuth type 3, which we said is type 3A, where the floor of the confluence is also healthy. So you have a good confluence. On the other hand, you have a type 3 where there is a ductal continuity, but fibrotic process has involved the floor of the confluence. And in these cases, it behaves and it is as difficult to repair and the results are as bad as a type 4. And we call this type 3B. This is what when Dr. Sikora was with us. So in these cases, type 3B and true type 4 cases, if there is an associated vascular injury, the threshold for doing a liver resection as the primary procedure slightly goes down. Normally, we try to avoid doing a liver resection for a biliary injury because what we are removing is normal parenchyma, healthy parenchyma. But if there is an associated vascular injury documented pre-operatively and during the operation, I find it difficult to find the right duct, or it is unhealthy, it is fibrotic, I know that this is going to restricture, then I would probably think in terms of a liver resection. So these are the two main implications of an associated vascular injury.
So Dr. Kapoor, there are a lot of questions. I mean, it's generated a lot of discussion. I also request all of you to just have a little patience because I will try to address all of them. But let's club a few things together because you started with perception problem and or avoidance of bile duct injury. And there are a few questions related to that. I'll sum them up together and ask you that if you talked about perception difficulty as the cause of bile duct injury, what are the critical steps to avoid bile duct injury? That is the question which is posed, and they've said you didn't mention anything about or you didn't address anything about the critical view of safety. What is the role of ICG? Do you use cautery while dissecting in the callus triangle? So could you just give us a sense of a couple of points, 3-4 important considerations to avoid bile duct injury?
I think for that, you will have to do another webinar. Sadiq, you yourself will have to do it. You are one of the masters of safe cholecystectomy. Yes, so the first and most important thing is that please do not take lap chole as a small operation. Give it as much importance, I would say even more importance than doing a esophagectomy or pancreaticoduodenectomy. And let me tell you why. If you have a mortality after an esophageal or pancreatic resection, in all likelihood, you will not face any problem. But if you have a mortality following a lap chole, there is very likely that you will face a problem. So please do take it seriously as a major operation. Do not take it lightly. And then, of course, the key thing is the critical view of safety, demonstrating that there are only two structures which are joining the gallbladder to the hepatoduodenal ligament before you clip or divide anything. But at the same time, we must remember that in our practice, especially in North India, many gallbladders, the Calot's triangle is obliterated or completely fibrosed or destroyed in the inflammatory process. And not only it is not possible, but it is dangerous to try to demonstrate this critical view of safety. And in those cases, you must identify that it is a difficult anatomy or difficult pathology. And then you have to use what are known as one of the bailout procedures, which could range from either retracting completely, not doing anything and referring the patient to a more experienced person, or if it is acute inflammation, coming back after 4 to 6 weeks, or resorting to partial cholecystectomy, which if you have skills, you could do laparoscopically also, or convert and do open. But most people now say that even after open, the procedure will be the same. So if you can do it laparoscopically, it can be done laparoscopically. So in a normal anatomy, to avoid the classical visual perception error injury of mistaking the common bile duct as cystic duct, it is the demonstration of critical view of safety. In a difficult Calot's triangle, it is the bailout procedure of a partial or a subtotal cholecystectomy.
And as much as possible, avoid using excessive cautery in dissection in the Calot's triangle. So there was a question about ICG. What is your view about ICG?
I have no personal experience, so I don't think I am the right person to comment on that. But those who use it, they say that it does show the biliary anatomy quite well and helps in dissection, but I have no personal experience.
So we have ICG and we are using it quite often. And so I think, I mean, there are two things about ICG.
Sadiq, we are losing your voice. We are not able to hear you.
Hello.
Yes,
Yeah.
now we can.
Can you
repeat the question?
Yeah, please repeat the ICG part.
So, yeah. Can you hear me?
Yes, please repeat the ICG part.
Yeah. So I was just saying that you need a special camera and the equipment to look at that, because you need to see it in that spectrum of light to see the ICG. So that is one investment you have to have in that. But once you have it, the advantage of it over a cholangiogram is that it is a dynamic process. You don't have to, cholangiogram is one time you do, and then you have to sort of correlate it with the anatomy at that point of time, which may be difficult. Whereas this has the benefit that you are seeing it at the same time live, whether there's a bile duct or not. The visibility is good. There is some issues about timing of giving the ICG, but most people feel that 2 to 3 hours prior to doing cholecystectomy, if you administer ICG, you would get a good delineation of the biliary anatomy. There are some pitfalls in that, especially in obesity with a lot of fat. The penetration of light is very less. It is about 1 to 2 millimeter. So if there is a thick pad of fat, or there is acute inflammation with a lot of inflammatory tissues, you may not get as good a delineation of the biliary anatomy. So this is about that.
Can I say something about the intraop cholangiogram?
Yes.
Again, we don't have very much experience, but theoretically speaking, my objection to intraop cholangiogram is, how do you do a cholangiogram? You cannulate the cystic duct. Now, if you cannulate the cystic duct and it was a visual perception error, what you are cannulating is actually the common bile duct. So you have already made a nick in the common bile duct. The other way you do an intraop cholangiogram is by putting a needle directly into the CBD, which I would be very hesitant. So intraop cholangiogram per se is an injury to the biliary tree. Where it helps is that if you have caused an injury, then to delineate the extent of injury or type of injury, intraop cholangiogram is good. But for prevention, I'm not sure whether it helps.
So yes, I think I agree that most a large literature which is reported do suggest that about 20 to 25% of injuries may be caused while doing a cholangiogram in these situations. But they also say that it's good to diagnose the injury on the operating table so that you don't miss it. So yes, those are the issues with cholangiogram. Some two questions have cropped up recurrently, so I want you to take it. One is, what is in a situation where there is an internal fistula post bile duct injury and the patient either is asymptomatic or has minimal symptoms, what would you recommend doing in this?
Yeah. So this is a frequent problem. There is a biloma which proximally is communicating with the bile duct, and then it ruptures usually into the duodenum and it becomes an internal fistula. So this relieves the biliary obstruction to some extent. Patient is asymptomatic, liver functions are mildly deranged or even maybe normal, but you do a cholangiogram and you find a complete transaction. So this is a frequent problem, and this is a very frequent question asked by the students as well as by practicing surgeons, what to do. Now, agreed that the fistula is temporarily decompressing the biliary tree, but it is not the permanent solution. It is not the ideal solution. These patients have subclinical obstruction and infection, and they can develop, and they do develop, secondary biliary cirrhosis. So even if the patient has no jaundice, even if the liver function tests are normal, even if there is no dilatation, if it is a transaction, I would do the repair. And as I said before, definitely before 6 months, so that the patient doesn't develop secondary biliary cirrhosis. The disadvantage is that the duct is undilated because it is decompressed. But what you have to do is that when you are doing that adhesiolysis going from right to left, once you reach the duodenum, keep looking for the fistula. Once you divide the fistula, when you see a drop of bile, first close the duodenum so that you don't forget it. And second, that drop of bile leads you to the bile duct. And diameter of the bile duct actually is not of much importance, because as we have repeatedly said, that this anastomosis has to be done to the left hepatic duct. So if you have a length of left hepatic duct, which is extrahepatic, even if it is an undilated duct, by doing this incision into the wall of the left hepatic duct, and because it is a side-to-side anastomosis, you can achieve a 1-2 centimeter diameter stoma. Now, ideally it is said 2.5 centimeter, but if you don't have 2.5 centimeter of length of a left hepatic duct, there is no way that you can get it. But if it is a healthy mucosa to mucosa anastomosis, I presume even 1 centimeter, if you can't get more, is good enough, but you should try to get as much as you can.
So one question you also answered in this was one participant has raised the query about how soon can there be secondary biliary cirrhosis? And you said that you want to repair.
Nobody knows, but most people agree about 6 months. I don't think there is any evidence.
In our publication, which we looked at biopsies in patients with benign biliary stricture, we have seen that this can occur as early as 3 months after the surgery. So it all depends on the extent of injury, the completeness of the injury, associated cholangitis, and these all can lead to even secondary biliary cirrhosis or at least fibrosis at an early stage. One specific question has been asked by Sujan Shrestha, that biliary surgeon, lateral injury CBD, less than 30% circumference, and you are on the table. So a repair has to be done, or you would consider a repair of this. What is your preference? Only a primary repair repair with a stent? How will you go about doing this? And it's in a good center.
Yeah. So first is that, as you yourself have said, that if you are a biliary surgeon, then only you should try to repair, because trying to put even a few sutures in a normal size CBD, if you are not careful, if you do not have and you do not use fine sutures, the sutures themselves can compromise the lumen of an undilated normal size bile duct. Whether to place a stent, trying to pass a stent or a tube into this duct itself can be a difficult exercise, especially if you're trying to do it laparoscopically. So you have to have a fine tube. If you use a T-tube, it should not go through the injury. It should go through a separate hole, and the sutures should cover the complete length of the injured part of the duct. You could even use a completely intraductal stent. So you can request a stent from your endoscopy colleagues and place it and pass the distal end beyond the papilla into the duodenum, so that later on it can be removed endoscopically. If logistics permit, you could ask your endoscopy colleague to help you endoscopically, intraoperatively, and you could even avoid a stent and just do a primary repair. But then the threshold for post-operative stenting will have to be low. I don't think there is much evidence on this, that whether using a stent or a T-tube is better or not using it better. So I don't think there could be an answer to that.
So let me put in my 2 bit in this. In this situation, I agree with you, specifically if you say that there is an undilated system. Trying to place a stent through this rent is risking increasing the size of the rent. So I would exercise 2 options. Primary closure, if it is a neat cut without any associated injuries, I would repair it. I have luxury of requesting my endoscopic colleagues to come in the theater at that time. And in that situation, I might request them to do an intraop ERC and place a stent.
That's the
If
idea.
not, I would just do a primary closure and look at it in the post-operative period and have a low threshold to go in for doing a ERC and stenting in case there is a early bile leak. One more question is, what is the timing of surgery? So timing of surgery, there are a lot of questions. And it's an important thing. We all realize that timing of surgery is critical. We've talked about early, we've talked about bile leak and biliary fistula timing of surgery. What about timing of surgery with a vascular injury associated?
So timing of injury, the SGPGI philosophy, and that is the philosophy accepted and followed by most centers across the world, is what we call a delayed repair, which means that fistula is controlled, sepsis is controlled, patient has recovered from the previous surgery and its complications. Fistula has closed, there is a stricture formed, there is proximal biliary dilatation. So that's the ideal situation. Definitely not in the first 4 to 6 weeks after the surgery. The only exception where we would not wait and may do an early repair is if it is a lap chole, if it is a clipped duct, completely divided duct, there is no bile leak, which means that there is no peritoneal sepsis. Fortunately, there is no biliary sepsis in the form of cholangitis. Bilirubin is rising very rapidly. You do an ultrasound or an MR cholangiogram, you see a good favorable biliary ductal anatomy. There is already some dilatation. This is one situation where I would not say that you wait for 4 to 6 weeks. There are cases where we have gone early and done the repair because there will be no adhesions and the duct will not be inflamed. So this is an exception. Otherwise, if there is bile leak, no repair before 4 to 6 weeks. And then, as we discussed, in some patients, you may have to wait even a little longer.
And with vascular injury, definitely you will wait.
No early repair. No early repair.
That is absolute contraindication for
an immediate or early repair.
And therefore, if it has been referred to you from somewhere, you would want to know the extent of injury, whether the associated vascular injury is present or not. And even the presence of a vascular injury, early repair is absolutely out. But how far would you wait? is it the same period or it will be much longer?
In vascular injury?
Yeah, associated vascular injury.
No, I don't think there is any evidence to say that you should wait longer for a vascular injury. Although you might say that if you have a vascular injury, there are more chances that you will develop an atrophy, hypertrophy, especially if it is a portal venous injury, not hepatic. Most common associated vascular injury is actually the right hepatic artery injury. In a normal liver, non-cirrhotic liver, if the portal vein is patent, a hepatic arterial injury usually does not cause any problem. So it doesn't change the overall plan of management of the patient.
But in a complete transaction with a hepatic artery injury, so biliovascular injury, the likelihood of the vascularity of the bile duct being compromised is high, and therefore you need to give enough time. So maybe I'll wait about 3 months minimum for this to see the stricture to mature completely, to understand the effect of the vascular injury, and then undertake the repair after determining the anatomy at that point of time.
But in any case, irrespective of the level or type of injury, all anastomosis have to be done at the hilum. So there was a question about choledochojejunostomy. No, for biliary stricture, every patient, irrespective of the type of stricture, should have an anastomosis at the biliary ductal confluence.
All right. So one question was that if you're doing an HJ and there is a bile leak at that time, although it is not directly related to this topic, but since we are repairing it and we are doing an HJ and there is a leak at that time, how would you manage?
Leak.
What would you do? You have noticed that your anastomosis is not very secure, and there is a leak while doing the HJ from the, maybe from the suture side or needle prick side.
So if the routine practice which we do is that once we've completed the anastomosis, we usually clean the area, suck it dry, place a gauze piece all around and wait for a few minutes and see if this gauze piece is getting stained with bile. Now, if the posterior gauze piece, which is lying posterior to the anastomosis, is stained, that's a more difficult problem, because anterior is easy. You can take another bite and control it. Posterior is the problem. Now, if it is a small leak, as evidenced from the amount of bile which is staining the gauze piece or flowing, then I would not do anything. I would just maybe, in every case, we leave a drain. In this case, I may leave an extra anteriorly placed suction drain so that the inevitable bile which will leak in the post-operative period is all drained from the peritoneal cavity. But if it looks like a major leak, then probably you will have to dismantle and redo the anastomosis. So it's a very difficult subjective assessment of the amount of leak from the posterior wall which you have to make. Also, we have to keep in mind that look very carefully whether it is a leak from the anastomosis or it is a leak from a duct which you have missed. Because in a type 5 injury, it could be a duct in isolation, which was part of the stricture. And now when you have dissected, you have anastomosed the jejunum to the main ductal system. But this isolated subsegmental, segmental, or even sectoral injury you have missed, and it could be leaking from there. In that case, what you have to do is to do a separate anastomosis of this duct into the same Roux-en-Y loop which you have made. So identifying whether it is an anastomotic leak or an isolated duct leak is very important.
So Dr. Rajan Saxena is there, and he, I think he has published some work on this. And sir, may I ask you to comment on this?
Let's start from the point about leak of hepaticojejunostomy on table. Last year, we published our report on testing the integrity of the hepaticojejunostomy. I have compared it with the swab technique of picking up a bile leak with the technique of air injection into the biliary tree. And if there is no air leak from a hepaticojejunostomy on table for a benign biliary stricture or a choledochal cyst or even liver transplant, then this patient is not going to experience a bile leak in the postoperative period. 1. 2, if at all you see air bubbles leaking out at any site, you know that that is the site of bile leak and you can effect a repair immediately. The second point I want to make about is the assessment of vascularity. You made a very pertinent point when you said that we are all talking about arterial injury and vascular injury. The arterial injury doesn't seem to matter. You said rightly, arterial injury matters because that is what is the main supply line of the common bile duct. And I've done some little work on this thing to demonstrate where does the bile duct receive its blood supply in a normal situation and in an injured duct. I have resin cast with that. Now, it is very evident if you injure the right hepatic artery to the right of the common bile duct, then you're waiting for a long period of time for vascularity to improve is probably meaningless. There's ample collateralization at the hilar plate. The technique of hilar plate lowering has to be extra cautious in these patients. You can't damage the plexiform arteries which are there, which are supplying the bile duct, and lower them to the extent of causing damage and then affect a repair. It's going to land up in trouble. The left hepatic artery, the left hepatic duct, receives the blood supply from the right hepatic artery behind the CBD in 81% of cases. Documented. And this is what is responsible for keeping the hilum healthy, the junction of the right and left hepatic duct. So these are factors which one must remember, that unless you have assessed the hilum, and the technique of assessing the hilum is triple phase CT. At the hilar arterial phase, you have to look at the hilar plate. If you see a good collateralization along the hilar plate, then the arterial injury will not bother you. The portal injury will anyway cause atrophy. And if the patient comes to you at a time when atrophy has already occurred, then trying to salvage a bile duct injury in an injured arterial and portal venous anatomy is an exercise in futility. It will never deliver what it is supposed to. This patient needs a primary liver resection for management of the biliary injury. That is one point. The third point I wanted to make was about the early use of ERCP. I want to share one experience. I was operating on an octogenarian physician whose tissues were reasonably friable because of a collagen tissue disorder also that he had. And his cystic duct got avulsed at its insertion into the CBD. That was Lapoli. So there were two options: open or get something done. On table ERCP was not possible. So we simply placed a drain, came out, sent a request to a medical gastroenterologist to put in a stent the next morning. Next morning, the stent was placed. Hardly any bile came out of the avulsed area. And the patient had his stent removed after 2 weeks with a complete healing. And he has been asymptomatic now for over 4 years. So there is a timing, there is a place for everything. But those who are very fond of ERCP must also remember some devastating consequences of ERCP. We have seen that also. A patient with bile duct injury referred from outside to medical gastroenterology, acute bile duct injury, underwent an ERCP. The bile duct couldn't be cannulated for some reason. There were multiple attempts, penetrating duct injections. And before the call could reach us, the patient had had florid pancreatitis, evolving into pancreatic necrosis, and finally the patient succumbed. So ERCP is not as innocuous a procedure as most of us would like to believe. It has its own set of problems, and you have to be very, very careful. If you do want to insert a stent on table when the injury has occurred, don't call the endoscopist. Make an opening into the bile duct and put an internal stent. It will work very well and can be removed very easily. But the whole procedure of endoscopic ERCP, making a sphincterotomy, opening up the papilla, injecting into one duct and then the other, this has consequences. And the complication rate of ERCP in the best standards of the world is 6%. 6% is not a small percentage. It is more than the incidence of bile duct injury that you have.
So the endoscopists will not agree with you. So these are surgeons. So, Dr. Baiju, thank you, Dr. Rajan. Dr. Baiju, do we have more time?
Yeah, no problem. Actually, I have a question, sir, about
Yes,
injury. If there is a continuity, do you suggest to put multiple plastic stents?
So endoscopic management, we have to understand that there are two stages where endoscopy plays a role. One is in the management of acute bile duct injury, where it plays a very important role, as I discussed earlier, in reducing or controlling the bile leak after bile has been drained from the peritoneal cavity. For this, just a single stent or an NBD is good enough, because what you want is to decompress the biliary tree. Second place where endoscopy comes in role is the definitive management of a biliary stricture, for which at SGPGI, all of us are against it. We say that if the patient is fit for surgery and if the biliary anatomy is such that we can do a hepaticojejunostomy, in all cases, we will recommend surgical management rather than endoscopic management. But yes, at the same time, our endoscopy colleagues do manage some biliary strictures endoscopically, and that is where placement of multiple stents. So they place multiple stents, 2, sometimes even 3, and these stents have to be exchanged every 3 months, and then they have to remain there for at least a year. After that, these stents are removed and the patient has to be followed up with LFT ultrasound and other imaging to see whether the stricture is reforming. But our philosophy is not to recommend. So while our endoscopists do manage some strictures endoscopically, from our OPD, no patient is referred for definitive management of a biliary stricture for endoscopic management.
Unless patient is
Yes.
not a good candidate for surgery or has portal hypertension, things like that.
Yeah.
I must ask you this question, Dr. Kapoor, because it's come up many times and Dr. Rakesh will get upset. How to differentiate benign from malignant biliary strictures?
Okay. So we are talking of not only post-cholecystectomy, any biliary stricture, because if it is post-cholecystectomy, usually in most cases it is benign. Although those who are working in North India, where gallbladder cancer is very common, keep in mind that sometimes patient may have had a cholecystectomy, either biopsy was not done, or even if it is not done, it showed chronic cholecystitis only, and still the biliary stricture can be malignant because of a recurrence of CAGB, and that you suspect if the post-cholecystectomy course was uneventful. There was no bile leak, and the patient comes back with biliary obstruction, and you do imaging, you see some mass lesion. So you then suspect that it could be a missed gallbladder cancer, which is now coming back with a local recurrence. Otherwise, by and large. So when we are talking benign versus malignant, I presume we are talking of non-post-cholecystectomy. And that is a very difficult issue. There are several ways. You can do brush endoscopically, brush cytology, you can do bile cytology. But today, the best investigation for that would be an US guided FNAC from the stricture area which you are seeing. Although I must say that it is not of much help in the sense that it is likely to be negative in a good number of cases, even if there is a malignancy. So a negative report doesn't help you. If it is positive, it definitely helps you. But if it is negative, it doesn't help you. So in a large number of these cases, although you do all these investigations, your final management, if the FNAC is negative, will depend on the cholangiographic findings and the clinical course. And therefore, to give the benefit of doubt to the patient, you have to treat them as malignant. Of course, in these cases, especially if you are planning or if you are anticipating a major operation like a hepatectomy on the upper end or a pancreatic adenoidectomy on the lower end, proper information, proper counseling, proper consent of the patient documentation is very, very important.
Thank you. Another question.
Tumor markers also form an part of the investigative workup.
Another question which has come up recurrently is, what are the operative tips and techniques in dealing with a biliary stricture associated with hypertrophy-atrophy complex?
So atrophy, hypertrophy, usually atrophy is on the right side because it is the right vessel which gets injured, right artery and right portal vein. So atrophy of the right lobe and hypertrophy of the left lobe. So it rotates the liver, and along with that, the hepatoduodenal ligament rotates anti-clockwise. And that anti-clockwise rotation, when it affects the hepatoduodenal ligament, the CBD, instead of lying anteriorly, the duct lying anteriorly, goes to the right and sometimes even behind. And the portal vein tends to become more anterior. So the place where you expect to identify the duct or the ductal confluence may actually be the left portal vein. And therefore, you have to be very cautious. In any case, in every case, you must always confirm what you are thinking as the bile duct is the bile duct by putting in a fine needle and aspirate bile. But in these cases, definitely you have to do that. And if you are planning to anastomose the right ducts also, these are the cases where, again, a pre-operatively placed percutaneous catheter right up to the hilum, right up to the end of the duct, will help you to identify especially the right ducts.
So what about hepatectomy in atrophy and hypertrophy?
Atrophy, significant atrophy, recurrent cholangitis in the atrophic segment, and a difficult stricture with associated vascular injury. These are some of the indications for a primary hepatectomy in biliary stricture. And then, of course, a recurrent stricture also sometimes becomes an indication for a hepatectomy. So the advantage of hepatectomy is that it gives a little better exposure of the left duct, and you can then achieve a good left hepaticojejunostomy. But at the same time, we must remember hepatectomy in biliary stricture is technically demanding procedure because there is no hilum to dissect. And sometimes you have to do this dissection parenchymal, in the parenchyma, and take the vessels as you encounter them. Because at the hilum, there is nothing, and you have to be absolutely careful that while doing this, you don't cause any damage to the left vessels or the left duct, because that will completely jeopardize the procedure.
Thank you.
One more
Now,
question.
with respect to, sorry, yes.
Yeah. Because it's the topic is benign biliary stricture, can I ask you one question regarding benign biliary stricture in chronic pancreatitis? How will you manage it?
I think Sadiq is a more experienced person on that to answer. I would leave it. I wouldn't answer it in presence of Sadiq Sikora.
No, Baiju, in this part of the country, now I'm part of this part of the country.
Yeah, you
we
can.
see a lot of chronic pancreatitis, right? So, yeah, I think biliary stricture, needs to be defined, that we need to make sure that in chronic pancreatitis with biliary stricture, you know well that we would want to rule out a malignancy in this, because a malignant bile duct stricture has a different connotation and management. So if there is a malignancy in chronic pancreatitis which has resulted in a biliary stricture, then it needs a Whipple's pancreaticoduodenectomy for sure. Differentiation and identification of malignancy causing the biliary obstruction is a challenge. Some morphological features of this stricture can help us differentiate between benign and malignant, especially a complete cutoff of the duct or irregular wall, shouldering in that area. So these kind of cholangiographic findings will help us differentiate between it. Very high bilirubin, high tumor markers, etc. If it is a benign stricture, I know that there is now a lot of controversy between endoscopic versus surgical management of chronic pancreatitis strictures. Again, although I'm a surgeon, but in the Asia Pacific meeting, I had a debate on endoscopic versus surgical treatment, and I was talking about surgery. And I feel surgical treatment is the best treatment for a stricture due to a chronic pancreatitis. A stricture which is not taken care of well will lead to secondary biliary cirrhosis over a long period of time. Endoscopic management is tedious, long-term, and requires multiple changes. Surgical management is one time. Doing it along with the pancreatic pathology we need to address, then you have to combine these two. So do a phrase procedure, which is what I do generally for a chronic pancreatitis, and add a biliary drainage with that in the same loop, or to a choledochoduodenostomy in this situation. Or if the pancreatic unit doesn't need intervention at that point of time, then in that situation, you would straight away go for a biliary drainage by a Roux-en-Y hepaticojejunostomy. So I would prefer a surgical treatment for that and a biliary drainage with a Roux-en-Y hepaticojejunostomy. One has to be careful about ruling out malignancy and the cause of that being a stricture in a patient with chronic pancreatitis.
Yeah.
Dr. Kapoor, again, one question about medico-legal features about chronic acute bile duct injury and bile duct stricture. So two questions pertaining to that. One is, as a postgraduate student, how to anticipate bile duct injury in a post-op case without drains, and should we be doing a screening ultrasound for all cases before discharge? That is number one. And second, as a biliary surgeon, would you recommend doing an angiogram in all patients prior to repair of a bile duct injury for medico-legal purposes to document a vascular injury before that?
So anticipation or early suspicion or diagnosis of a bile duct injury, I would repeat what I said earlier. If the patient is not feeling well, if there is any instability of any of the vital signs, if abdomen is not completely normal, please suspect a bile duct injury. It could be anything else, but please suspect and at least rule out a bile duct injury. And this patient should not be discharged. This patient should be further investigated. As I said earlier, you do counts, you do liver function tests, you do an ultrasound, and then depending on the logistics, the clinical condition of the patient, when and how soon to go for a further investigation, which could be either an isotope scintigraphy or a CT or an MR, would depend on the clinical condition of the patient. Angio before repair, theoretically speaking, ideally speaking, yes. And that is why when you do an MR to do a cholangiogram, you should probably do an angiogram also, as the questioner himself or herself has said, that one for medico-legal purposes, because while doing a repair, we can cause an injury, especially to the right hepatic artery, as it is coursing in front of the duct and it is engulfed in that fibrous tissue. So while we are dissecting, we can cause an injury. And if that injury is then detected later, the patient may come back and say that you caused the injury during the repair. So if you have demonstrated it was already there. So that is the medico-legal aspect. But I think more important than that is especially if you are dealing with a difficult, and difficult means Dr. Sikora's type 3B and type 4 stricture, where you anticipate that the right duct may not be good for anastomosis. If there is an associated vascular injury, as I said, that decreases the threshold for considering a hepatectomy. So that is the only reason. Otherwise, by and large, vascular information would not change my plan of management. If the stricture is repairable, even if there is a vascular injury, I would probably repair it. Except the fact that timing, which you mentioned, that in a patient like this, you probably would wait a little longer, which is okay.
So you also said that who is repairing is important. So there are questions pertaining to that. I'll combine all of them. So one question is, if I'm a, say, so-called HPB surgeon and I have injured the bile duct, should I repair it or should I ask somebody else to repair it?
Yeah.
That is number one. And the second question is, as a HPB surgeon, when you are called to repair acute bile duct injury, what are the considerations you would take into account and what you would do and what you would not do?
Yeah. So one is who should repair, and this we have been saying it, and now SELSI, the Society for Endoscopic and Laparoscopic Surgery of India, has published its guidelines, in which both I and Dr. Sikora were involved in the Indian Journal of Surgery. I request all the general laparoscopic surgeons to kindly go through that. It has very strongly recommended that if you are not a biliary surgeon, please do not attempt to repair for two reasons. One, it is very likely to fail. And second, if it fails, the re-repair, even if it is done by a biliary surgeon, is going to be difficult for him also. And third, obviously, as I said, that you are more likely to face a medico-legal problem, that why did you repair when you were not experienced or you were not expert on that. The second question, that if you are a hepatobiliary surgeon and you are asked by somebody else to repair, obviously you have to delineate the type.
Dr. Kapoor, before that, if I have injured, should I repair?
Oh, sorry, I forgot. Yes. Ideally speaking, no. Because you see, if I have cut the bile duct, I am not in a frame of mind to repair that. Best for me would be to go to the lounge, have a cup of tea and coffee and sit there and request either Dr. Rajan or Dr. Sikora, if they are available in the same hospital or in the same city, they can come within a reasonable period of time. I personally think it will be much better that some other person repairs it, because he comes with a fresh, unbiased, unburdened mind. I have fear, anxiety, worry, guilt in my mind. And in that process, trying to repair a bile duct which is normal size, I don't think is the ideal situation. The second question, that if I am going to help a general surgical colleague, yes, I must do a complete assessment of the type and extent of injury, whether it is a lateral, whether it is a complete transaction, whether it is the main ductal system, whether it is an isolated segmental or sectoral duct or a cholecystohepatic duct. It could be that what the surgeon thought is a complete transaction is only a cholecystohepatic duct or an aberrant isolated duct in the Callot's triangle from which bile is coming. So assessment, and this is where intraop cholangiography is of great use, that you put a fine cannula through that opening and do a proper cholangiogram and see what all ducts are seen, whether the distal duct is seen or not, and do a complete assessment of the ideally, you should have a vascular assessment. So you should have intraoperative Doppler to assess the vascular injury, because as we have repeatedly said, a presence of a vascular injury, most groups, even those who do an early or intraoperative repair, say that should not be done. So if these two are important components, assessment of the ductal injury and assessment of vascular injury.
So I would just add a couple of things, if it's okay. I would also like to review the whatever has happened till that time. If it is a laparoscopic collision, review the video. So I think that gives a lot of information, especially regarding vascular injury, if there's been bleeding, if there's been clipping of ducts, and so on and so forth. And also the extent of injury can be assessed at that time. So I would review that as first thing.
Because
Second,
the first point in the video where the bile is seen, that will tell you now retrospectively what is the type or extent of injury.
Then I agree with you that assessment at that point of time of the biliary anatomy is very critical, and you may even do a cholangiogram at the table, because it has been shown that repairs done without a cholangiogram have a high failure rate as opposed to those with a cholangiogram. Also, the Mercado has shown that high repair is better. So we should not at the site of transaction. So if it is a low transaction, I would not do a repair there. I would go up. And as a matter of fact, in an undilated duct, I would also open up to the left duct to get a wide fish mouthing of the duct, so that you can get a wide stoma and anastomosis of that. And the usual thing about fine monofilament sutures and precise placement of sutures, especially if magnification is available. In such a situation, it would be of great use. So I think we have covered most of the queries related to that. Dr. Baiju, I'm sure there are a few which I've missed. There are some which are...
directly. Dr. Arun, can you please open? Yeah. Please unmute.
Okay, sir.
Your comments or questions?
Sir, it was something like a revision just before our final exams. Whatever we have learned from our MS days, from our GA surgery training days, fellowship days, from the great institution with the maximum amount of biliary surgery experience, especially bile duct repair experience. I mean, not only just India, but one of the excellent centers, high volume centers across the world. And it is not an exaggeration to call SCPJ Lucknow as the Mecca of biliary disorders in India, because we learned a lot, and so many surgeons, younger surgeons learned a lot, and it was a it was a very quick, precise, crispy revision with huge inputs, not only from Kapoor sir, but also from Sikora sir. So it was a very, very good revision for all of us. And it's very important. It's very important because any surgeon who do a cholecystectomy, laparoscopic cholecystectomy, definitely will need revision with period of time. So it was a visual treat, a great experience. I would say we could see Dr. Kaushik as well, Professor Kaushik as well. So it's a mini alumni meet in the difficult COVIDian times. Thank you very much, Baiju sir, for this experience, and my sincere thanks and gratitude to all the teachers.
I see Dr. Praveen Bhatia there.
Yeah. Thank you very much. It was a wonderful presentation. And I would put it this way, that wonderful discussion by Dr. Sikora and Dr. Kapoor. Thoroughly enjoyed that. I would just ask one small question. Many times, the surgeon may not even come to know that he has gone very close to the CBD and then caused the stricture. He would think that he has done a great job of doing laparoscopic cholecystectomy. So what is the incidence of biliary stricture in those situations?
Yeah, Dr. Praveen Bhatia is right that if you are working very close to the CBD, if it is a thin-built patient with not much fat around the CBD, and if you are using cautery in the callus triangle, especially at high wattage, my policy is, or our policy is, that when we are working in the callus triangle, we make sure that the wattage is reduced to around 20 or 25. And then when we go to the gallbladder bed, then increase it. So thermal injury to the bile duct may not cause bile leak intraoperatively. It may not cause bile leak even on day 1 or day 2 when the patient is in the hospital and patient is all right and goes home. It is after 3 to 5 days that thermally injured bile duct wall part gets sloughed and causes bile leak. And therefore, it must be a routine that every patient who has undergone lap chole and is discharged must be told to come back to you, not to anybody else, if there is any problem in the next 7 days, even if it is an MI or even if it is an attack of bronchial asthma. Because once you see, you will make sure that it is not a bile leak and then send the patient to a physician. But if the patient goes to a physician first and has a bile leak, definitely it will be missed because they will not even think about it. So any problem within 1 week, the patient must come to you. The third is if there is a thermal ischemic injury to the bile duct, so that there is no necrosis. And theoretically speaking, it can cause a very late stricture, which manifests months and years after cholecystectomy. But we don't have much data on that. It is just a theoretical kind of derivation that a thermal ischemic injury to the bile duct can result in a very late stricture without a bile leak in the postoperative period.
And Dr. Sikora, what is your viewpoint? If the surgeon has applied the clip on the lateral wall of the CBD and that develops a stricture, maybe not the leak, not the injury in the near future, but later on. So Dr. Sikora, what is your opinion about it?
I think it needs to be managed. It's presented late, isn't it? You're saying it's presented late as a partial stricture, perhaps with recurrent cholangitis, some raised GGT, SAP, and things like that. You know, again, as Dr. Kapoor said, I would prefer, if there is a stricture, the anatomy is good, I would definitely prefer a surgical repair. But this, having said that, I know that in most of these repairs, especially good anatomy repairs, we can have almost 100% good results over 8 to 10 years. But this is one of the situations where endoscopic treatment would also be feasible because it's a partial clip which is applied, and these are amenable to endoscopic management. And if you have a good endoscopist who can do this endoscopic treatment with dilatation, multiple stents placement, I think this is one of those situations which can be managed with good long-term results.
Sure. And Dr. Kapoor, in your algorithm, I don't find EUS.
For bile duct injury or for biliary stricture?
For bile duct injuries.
I don't think EUS its role will be, as we discussed, in differentiating benign from malignant biliary stricture. But in the acute bile duct injury, it's mainly endoscopic cholangiogram and stenting and ENBD placement, which is important.
Right.
Yeah, there was a question in the chat box regarding how to approach a restructure in SJ.
Okay, so just to be very brief, our policy is we find out who did the first repair, whether it was done by a biliary surgeon or a non-biliary surgeon, because we presume that if it was a biliary surgeon, a proper left hepatic duct repair must have been done. And then we look at the cholangiogram, whether the left duct is virgin, untouched. So if the repair was done by a non-biliary surgeon and cholangiogram shows that the left duct is virgin and untouched, we would go in and do a proper confluence, biliary ductal confluence through NY hepaticojejunoscopy. But if the repair was done by a biliary surgeon or our own repair, and the left duct is not there and the stricture is at the hilum, then the first line of management is a interventional radiology, percutaneous balloon stricture dilatation.
If there is a spontaneous utilization of the bile, will there be any change in the timing of surgery?
Sorry, please say again. I couldn't hear the first part. If there is
into duodenum or stomach, will you change the timing of surgery?
No, no. We discussed this internal fistula. The patient will be asymptomatic, ducts will not be dilated. You may wait for some time to see whether the fistula closes and strictures dilate, the ducts dilate. But that upper limit of definitely 6 months, and as Dr. Sadiq warned that some cirrhosis can occur as early as 3 months. So definitely not beyond 3 to 4 months or maximum 6 months.
Okay. In your talk, you are talking about a suction drain. That was purposeful or?
No, the usual drain is a single non-suction 24-28 size Portex drain, Portex tube, which is placed behind the hepaticojejunoscopy. That's good enough in all majority of cases. I said an extra drain anterior in case I'm not happy with the anastomosis, in case there was a leak which I am not able to control, because then I suspect that there is going to be a bile leak and it may collect inside. So just an extra drain, which usually I put anteriorly, and since it is anterior, it is a suction drain.
Yeah. If you are placing a drain anterior, that will be a suction drain, right?
Yes. But that will be only if there is a anticipated bile leak.
Okay. Anybody wanted to ask questions directly? Dr. Ashok Baranik?
Okay, am I audible, sir?
Yeah.
Yes. Yes.
Okay, so good evening, everybody. I think there is a decreasing trends and much of safety precautions the newer trained doctors are applying. I see, do you see any decreasing trends in the formation of biliary strictures in last decade or so? This question is to all people who are expert in the field and who has been probably referred all these cases. So they can comment on this, that do you find there is an improvement in the training, improvement in the performances of the junior doctors and the gastroenterologists, and we are witnessing now the decreasing trends in the biliary strictures, atherogenic injuries?
I don't think there is any data in our country about this, but if we talk of our experience, we see the same number or maybe even more cases, but that may be a referral bias because we are a referral center. But data from countries where there is national data keeping and recording, it's not showing any downward trend. The incidence of
fair enough. Because in my practice, I don't come across much of such these cases. So that's why, yes. Thank you.
Yeah, thank you, Dr. Ashok. Dr. Sikora, you can have your final comments and close the section. And after your comments, a speaker will be giving the final conclusion remarks.
I mean, I think we've had a very healthy, very interesting, very rejuvenating discussion throughout this almost 2 hours of this session. And we've gone through most of the things as it is. There are a lot of queries still which have remained unanswered, but I think it's now indication to you, Baiju, that you need to have another session on this. Looking at the...
as you are the speaker, I'll fix a time later and then I'll let you know.
I think it is, we've covered most of the things, and as Dr. Kapoor has rightly emphasized on some of the things, that what to do and what not to do are the key. So as everyone has said, timing is the key. We need to pay attention to timing, and in different situations, the timing plays a role. Who does it plays a role. So keeping these in mind, if you pay attention to that, you'll succeed in doing good to these patients more often, and specifically in a situation of bile duct injury resulting in a stricture, you would sort of make sure that you don't take any undue or steps which are not recommended, and go through the right pathway so as not to end up with a case against you and things like that. So having said that, I let Dr. Kapoor close this session.
Actually, Dr. Balashamo has raised his hand. And before the final conclusion, Dr. Balashamo, can you please unmute your mic?
Hello.
Yeah.
Yeah, can you hear me, Baiju?
Yeah.
Yeah, one last question, because excellent discussion was going on. I want to know from Professor Sikora and Kapoor about the role of a gastric access loop in hepaticogynostomy.
Sadiq,
Access loop to the stomach with hepaticogynostomy. What is their experience? What is their opinion?
So, Dr. Bala, hello, how are you?
I'm fine, sir. Thank you.
So, this question, to be very honest, I am a non-access looper. So, I feel the only role of access loop post-HJ is in patients with intrahepatic stones, recurrent intrahepatic stones, wherein you would need access to the biliary system again and again. And in that situation, either to the stomach or to the second part of duodenum is a good enough access loop for endoscopists to access the biliary system and take care of the stones. For bile duct repairs or HJs, I'm not in favor of making access loops either in the stomach or even to the exterior, because I don't find these to be of any benefit in these patients. And with the better experience of interventional radiologists now, it is always good to approach this from top down rather than from bottom up. And therefore, with the good experience and expertise available with that, if there is a problem subsequently in an HJ, we can always have our intervention radiologist access this and take care of this. So I am a non-access looper.
and also bile gastritis is a very severe distressing problem.
Yeah. Dr. Narvari has also raised his hand. Dr. Narvaria.
Yes, good evening. Good to see all my 4 teachers together on the screen.
People are there.
I really enjoyed the talk and discussion. Yes, last 2 hours I was sitting. You must be surprised a bariatric surgeon sitting for 2 hours and listening gallbladder.
Very surprising.
He also listened to bariatric surgery. Don't worry.
Only
15 minutes में आया होगा अभी बैठने
नहीं सर आप अटेंडेंस देख लो बैजू लिखता है सबका. So
Yes.
what is the future of surgery in the scenario of advancement in endoscopy? Because a lot of endoscopists are trying to do bilioenteric anastomosis using endoscopes while using the ultrasound, EUS, and a lot of stains which are available. So do you think the future will be able to manage this only by endoscopic therapy?
Yeah, theoretically speaking, you may be right, because basically what we need is a mucosa to mucosa anastomosis between the bile duct and the jejunum or any part of the GI tract. And the new lumen opposing stents, which they are using, can achieve that goal. But then how do you place something in the bile duct and then the jejunum rule loop goes there? Maybe someday some technique would come, but as of today, the endoscopic management is only in the form of stenting, which we discussed, which all of us at SGPGI feel is not the ideal treatment in a patient who's fit for surgery. So as of today, except very few strictures, as Dr. Sadiq was trying to say, where it is a low stricture, partial stricture, incomplete stricture, where you may, although we don't, you may refer the patient for definitive endoscopic management, but we would not, because these are the patients in whom surgical repair is almost 100% successful.
True.
And the repairs which are difficult to us, endoscopists would probably not even touch. Complete transactions and very high strictures. So someday, if you have some interventional radiology and endoscopy rendezvous approach by which you can put a lumen opposing stent between the bile duct and a root loop of jejunum, which achieves the mucosa to mucosa anastomosis, yes, that would replace surgery, definitely.
Thank you, sir. Thank you so much.
Saxena, sir.
Sir, I would like to make a comment on Mahendra Nawaria's question. Stenting, one after the other, have been developed over the last nearly 40 years, right? And we have seen them progressing. Initially, people were not even able to retrieve. Then Sohendra's extractor came in. Then extractable stents came in. Then self-expanding stents with covering came in. These are modifying because the final word has not been written on that side or this side. What has stood the test of time is a one-time definitive surgical treatment for an iatrogenic problem, which can ensure that the patient lives normally through the longevity of his life, as against a procedure that demands multiple visits in and out of the hospital, and at every procedure, an added risk of the procedure itself. So answer one question to yourself as a doctor. If one of your relations gets involved in a bile duct accident and develops a stricture, what would you prefer? Be honest to yourself. A lot of claim, Costa Magna's claim and others who have started coming in. Now I'm going to put up a series of patients who have been treated by endoscopic stents and then have come to surgery. What happens then? 3 years, 4 years, 5 years. They miss the isolated ductal systems, which are persistently discharging mucositis. So it is not the issue that they couldn't have done it better or they shouldn't have done it here. The issue is the person who is handling the problem, does he understand the problem in its entire magnanimity? Is he able to appreciate the anatomical considerations? Is he aware of all possible combinations and permutations? We have published an article on the BPR approach, the Bear, Prepare and Repair approach to the management of external biliary fistula, right? It's in a textbook. Now, the most important thing highlighted there was that if you're going to do a corrective surgery on the biliary tree, don't venture in till you have mapped every single segmental duct, and on table, you have accounted for drainage of every single segment into the loop that you're going to provide there. Vinay's use of the term hydroplasty may be controversial a bit, but the purpose is you go as close to the hilum as possible to ensure that every single duct is opening into the new stoma and the new conduit. If you leave a segment undrained, the problems in the post-stricture repair phase are even more difficult to appreciate. The patient continues to simmer with some kind of cholangitis because one system is excluded, it is infected potentially, and it continues to shoot problems. It may undergo atrophy after a period of time, the patient becomes silent. But if you investigate them, you find that there is a ductal isolation. So this is a problem that needs to be understood in its entirety. Before one person says, no, this is the only way to treat it. We have gastroenterologists now who are saying that endoscopy is better than surgery. It avoids surgery. The issue is not avoiding surgery. The issue is curing the stricture. What cures it? You are providing a scaffolding, which is providing fibrous tissue to remain there. It remains quiescent for a year. And then once you withdraw it, the fibroblastic activity resumes. It has been documented. And then the strictures reform. It is not a one-time answer. If you read Cattler and Brash's article of 1959, the then surgery, gynae and obstetrics, where they have discussed the pathophysiology of evolution of a stricture from the time of injury till the time of presentation to the surgeon, how a core cylinder forms the fibrosis. There are experimental studies showing the documentation of the procedure. And we know when a technical surgery is failing, it failed because you ventured into that fibrotic wound. That's where you try to fix the joint. That's what you picture anyway. So understanding the pathology, understanding the pathophysiology, and the greatest detail of anatomy, not only of the biliary tree, but also of the blood supply, is paramount. Everyone talks of extending onto the left duct. Has anybody ever talked to you when to stop on the left duct? There's a landmark. It has never been discussed in our sessions and never been talked to students. When to stop. There's a limit. If you are going a millimeter beyond the ligament, the umbilical fissure, you are inviting trouble for yourself by disrupting the collateral circulation. So these are do's and don'ts which need to be understood in a broader manner for a person who's going to delve into these areas. And our surgical team has had the privilege of working so focused in such a focused manner over 32 years with this problem that we have some answers. I don't say we have all the answers, we have some answers.
Thank you, sir. And final words from V K Kapoor, sir.
No, I would just say thanks to you. Thanks to Sadiq for moderating and for a very fruitful discussion, and to Dr. Rajan for adding in. And although Dr. Kaushik has left, he sent me a message that he had to leave, but thanks to him. Thanks to Arun, Mahendra, and I see some other of SGPGI alumni. I think Avinash is there. Ibrar was there. So thanks everyone. And thanks to the senior members who attended the webinar. Thank you very much.
Thank you, sir. Thank you once again. And thank you all the senior members and all the participants for making this SCF webinars a great success. Actually, we will be coming with another session of webinars next year. Till then, I say bye to you. Good night. Good night all. Thank you.
Thank you.
Good night, Baiju.
Good night. Good night.